Hi there. My name is Michael Vallis. I'm a health psychologist from Dalhousie University in Halifax. And I'd like to make this presentation to you concerning the really important concept of diabetes distress, some of the burdens associated with diabetes, and importantly, how we can move from being overwhelmed to being empowered. These are my disclosures, the interactions that I have with for-profit companies. And the reference point for my presentation is the following. Psychological issues associated with diabetes are certainly not experienced by all. Very few people experience psychological issues with diabetes all of the time, but many people experience occasional time-limited problems. And managing diabetes is really around overcoming challenges. And so in some ways, we need to accept the condition and work with it. And this is where the distress and the mental health aspects of diabetes become so very important. And it's critically important for us to put the distress associated with diabetes into the proper context. And so I'd like to explain that to you by talking about mental health really as a continuum. And this is quite an important perspective really to appreciate. And let me explain it to you. Because it really just describes life and our experience of the events that occur in our lives. And what I mean by that is the perception of threat will naturally lead to the feeling of anxiety. The perception of loss naturally leads to the feeling of sadness or depression. And the perception of intrusion or unfairness leads to the perception of the experience, rather, of anger. So if you're feeling irritable, if you're feeling resentful, if you're feeling sad, if you're feeling anxious, it's sometimes useful to think, okay, what's the threat? What's the loss? What's the point of unfairness? Because this then can give you a framework from which to move forward. And what's important about that is because psychologists divide up emotional experiences that people have into two general categories. And as you see, one category, which describes many experiences that we have from a mental health point of view, is what we call primary emotions. And this is where you would expect that the threat would create anxiety. And a little bit of threat should create a little bit of anxiety. A lot of threat should create a lot of anxiety. A threat that doesn't go away should create anxiety that lasts. And I'm hoping that you can see how I'm normalizing that experience, because what's really important about this is life is filled with stresses and strains, and those have emotional impact. And what's important about there is how we cope with those emotions, how we go to move forward from those emotions. And it's really by expressing them, not keeping them bottled up, and actually seeking support. And so that happens everywhere. So that's really important, I think, in terms of an empowerment point of view, acting on your distress as appropriate. But it is important to note that sometimes stress gets overwhelming. We call those secondary emotions, and that's when you start to see some of the emotional difficulties. And so don't assume, if you're struggling, that in fact there's a significant problem. It may be that this is something that can be managed if it's faced and supported. It's important to understand the human condition, and when you think about the fact that we have our plans, we have our organized approach to life, and all is good, but then life is also full of stress. And what's really important to understand is that as stress goes up in a person's life, it's really common for self-care to go down. And so this is why it's important for us to identify the stress so we can take action on it. And this is a point that I think is worth thinking about, is that currently in our society, and certainly inside the medical system, we really have only one way to talk about mental health, and we tend to talk about it in terms of the diagnosis of mental health disorders. So the language is often, you're down, well, maybe you're depressed, or maybe you have an anxiety disorder, you're struggling with, maybe you have a personality disorder. And so there's the tendency to use language that really defines significant mental health disorders, and those are based on really what's called the diagnostic manual, and it really identifies psychopathology is the term, which really means pathology of the psyche. But maybe the experiences that people have are more normal. That is, perhaps they're not abnormal and fall outside of what would be anticipated, just like what I'm describing about perception of loss, threat. And so this raises the question as to whether the emotions that someone is experiencing should be seen as just part of life to be managed or something that really needs help. And if we look at this kind of continuum of distress, then at some point, the distress becomes so high that it interferes with functioning. And this is where the diagnosis comes in. But there's a lot of journey before you get to that point. Anxious when threatened, sad when experiencing a loss, angry when experiencing unfairness. And so this sort of normal understanding of emotions leads us to try to understand, okay, how do we really understand ourselves? And so a really useful way of thinking about this is what we call quality of life. And what's important about quality of life is that it identifies distress as an important component, but it doesn't stop there. Quality of life is a balance between distress, the things that pull you down, but also well-being, the things that bring you up. And shifting from overwhelmed to empowered sometimes means focusing on the well-being dimension, not just the distress dimension. What I like about this model is it allows us to understand, okay, if you're feeling distressed, what's driving that distress? And that distress could be driven by the chronic disease, by diabetes itself. And we know there's a lot of aspects of diabetes that do cause distress, which I'll talk about. But it's also important to understand that just problems of living, what we call the social determinants of health, so income, location, marginalization, life event stresses that are really just main barriers that would get in the way. Social services can sometimes be really, really useful there. And also, we recognize that there could be psychopathology here. So this is a model that maybe guides you a little bit in terms of how do you manage the distress that you're experiencing. But equally important with this is this idea that we can talk about positivism or resilience, coping skills, building on your strengths. And so I know this is a talk about diabetes distress, but I think it's important for us to contextualize this by thinking about positivism. What can you do to enhance the positive experiences in your life? And this is really what we call a strength-based approach that promotes really resilience, that ability to get back. And there's research in this area around happiness that tells us that that happiness isn't really the result of huge accomplishments and huge efforts, but actually small daily habits that really determine well-being. And habits that are shown to be consistent amongst people that are, naturally happy. They devote time to family and friends, they practice gratitude and optimism, they savor life pleasures, engage in meaningful activity, they're able to stay in the moment. So there does seem to be some strategies that we could adopt that might actually build on our positivism. And when we look at noticing the good in life, what we see is that intentional activity seems to be an extremely powerful determinant of how optimistic, how much of a positive attitude that you take. Genetics plays a big role, but there's a lot that we can do. And optimism, therefore, really could be looked at as a habit. So as you think about managing distress, please also think about what you could do independently to increase the positivism in your life. And so we sometimes talk about these happiness interventions, as you see here, regularly setting aside time to recall moments of gratitude, positive thinking about oneself, practicing altruism and kindness, affirming your most important values, and savoring your positive experiences. Now, this is an attitude that one can adopt that's been associated with improved coping. And so I wanted to put distress presentation in the context of happiness at the same time. And so now let's talk about distress. And this, I think, is relevant for most of us. And so if you're living with diabetes, if you're a family member or affected by diabetes, then it's important to recognize potential sources of distress. And if we ask this question, what's distressing about diabetes? We actually have a lot of answers. The behavioral demands of self-care can be overwhelming. There's a lot of work to do. Maintaining glucose control is actually complex. Diabetes self-care demands are constant. There's no real breaks. And diabetes can be unforgiving, and diabetes is certainly plagued by uncertainty. And so what you see there is the threat and the loss and the unfairness when you think about what it's like to navigate the world of diabetes. And so this really justifies kind of the normalization of the concept of distress. And so one of the things that we find helpful when we think about the concept of diabetes distress is to really understand what's driving it. And in particular, we like to frame diabetes distress in terms of what the source of distress is, because then you can direct your coping resources towards those. Let me be more clear. The first aspect of diabetes distress that we like to identify is what we call the emotional burden. The sense that you're feeling overwhelmed or feeling bad about yourself because of your diabetes, that emotional weight. If diabetes was a weight that you carried in a knapsack, would it be a 1 pound loaf of bread? Would it be a 5 pound bag of potatoes? Would it be a 50 pound iron anvil? Would it be a 2-ton truck? What's the emotional burden? Second, what distress is associated with all of the self-management tasks, what we call regimen distress. The self-monitoring, the monitoring activity, the record keeping, the medical therapies, the monitoring your feet and eyes over time. All of the tasks that could be ever present in a person's life can be burdensome. And then there's the relational aspects of diabetes. We don't experience or live with diabetes in isolation. And here we talk about provider-based distress, something that as a psychologist I think is really important for individuals living with diabetes and healthcare providers to acknowledge, which is sometimes the medical system, the relationship with the provider can be distressing. And if you've ever felt like sometimes going in to see a medical provider around your diabetes, you feel like you're being called into the principal's office, or you're feeling guilty that you're not doing enough. That's the kind of provider distress that we'd like to identify so we can help you work through. And the final aspect of distress is what we call social support distress, people in your life. So emotional burden, if diabetes were a weight on your backpack that you carried around, how heavy would it be? Important question to reflect on. Because you may use words like you're feeling overwhelmed, you're feeling burnt out, you might experience what we call a sense of powerlessness, that there's nothing that you can do because of the complexity, because of the number of different factors that actually impact a person's glucose level at any moment in time. You can feel sometimes like there's not a lot that you can do to make a difference. And by identifying these, it'd be really important for you, because acknowledging them, bringing them into the care plan is in most cases the way that you manage these burdens. Regimen distress is really around the actual management tasks. Eating-related distress, as you well know, diabetes changes your relationship with food because of glucose in the food that virtually most foods we eat. So they do have an impact on your glucose levels, and therefore kind of food almost becomes like medicine in a way. And so that is a source of distress. And certainly hypoglycemia distress, which I'd like to talk about in a little bit, because it's also an important aspect. And so with regard to the regimen, is it just overall tasks or specifically related to food or to the potential for low glucose levels? And if you can understand your emotional experience, that's then the strategy that leads to the solutions that can be helpful to you. Provider-based distress. Have you ever felt like I can't really tell my diabetes doctor what's really on my mind, or my diabetes doctor providers don't really understand what it's like to live with diabetes. I don't really get the help I need from my diabetes providers. My diabetes providers don't know enough about diabetes care. And so you can see from what I'm presenting here, these are actually normal. These are common experiences that people have. And so we're trying to really open up the opportunity and encourage people living with diabetes to express these concerns to us so we can then help manage those. And social support distress, people might treat you differently if they find out you have diabetes. You may feel that you have to hide your diabetes from other people. You're concerned that diabetes makes you less attractive to employers. People will think less of you. And we do see there is a signal for diabetes stigma. And again, if you're experiencing this I think can be really beneficial for you to become aware of. Because when we understand the sources of our distress, so threat, loss, unfairness, then that allows us to direct our coping resources. And when it comes to coping, the best way to think about it is for you to identify what's worked for you in the past. So what are your natural coping strategies? What are the coping strategies of your friends or people that you trust, or people that you might be encounter who also live with diabetes who are able to manage the diabetes quite well. So can we learn from others? In other words, trying to really encourage us to problem solve and to really kind of identify the nature of the stress. The more specific you know what the problem is, the more you can match that to a strategy. And diabetes care is shifting towards providing you with the opportunity not only to problem solve around eating behaviors or exercise behaviors or self-monitoring of your blood glucose, but also your emotional experiences. Now, as we talk about diabetes distress, it's also important to talk about two relevant issues for diabetes that have sort of also been identified through this work that we've done in defining diabetes distress as a separate category. And that is for particularly with type 2 diabetes, there's often some concerns that people have around shifting from oral medication, just taking pills, to taking insulin. And interestingly, the term that's used is called psychological insulin resistance. I'm just showing you data from a large survey-based study. 16 countries were involved in the survey. And you can see that a great number of people with type 2 diabetes actually are concerned about starting insulin means that you've not really been able to do your job really well. So these are saying that this is actually a concern, and there are certain attitudes that people have around whether diabetes takes control away from you when you shift to insulin, whether that means your disease is more serious, whether it means that to you feel that perhaps it's a personal failure. So again, understanding these attitudes can be really, really important, because what we know is that type 2 diabetes can sometimes progress to the point where your pancreas doesn't produce enough insulin anymore. So insulin resistance becomes insulin insufficiency, and insulin is then required. And so asking yourself a number of questions might be really helpful in identifying any attitudes that you might have that would interfere with care. And the reason that I'm describing this is because there's a very recent phenomenon that we've become aware of in diabetes care called inertia. And that is when it's appropriate from a medical point of view for people's care to be intensified. But there's a delay in the intensification, and there's a number of factors that are responsible for that delay. And one of the important factors is your own attitudes. And so asking yourself and having an opportunity to talk about these attitudes might speed up the care, which results in better control for you. Do you feel that insulin will take control or freedom away from you? Do you think that starting insulin means that you've failed? Are you nervous about or anxious about injecting? Do you think that starting insulin is more work than it's worth, that you won't get any benefit from it? Do you think that insulin means that your disease is more serious? And do you lack confidence? These are relevant questions. If you could take these questions, if you struggle with any, into your provider, then your care plan can take these into consideration. The final thing that I want to really talk about is the fear of hypoglycemia, which we know is actually really, really common, especially if you've ever had a serious hypoglycemic event, which is when your blood sugars get low to the point where you can't really treat them yourself. And this is important because what we've uncovered is that this type of hypoglycemia experience is very stressful. It's a really powerful stress. And it's such a stress that people will sometimes allow their blood sugars to stay high in order to avoid going low. Showing you additional data about concerns about hypoglycemia. This is from that same study that I'd mentioned before, 16 countries, just showing how common it is for people living with diabetes to experience this fear of hypoglycemia. So there's a strategy that we've encouraged people to do that can help them to manage hypoglycemia. Sometimes what will happen is your provider will recommend you get your sugars under control. But managing the fear of hypoglycemia is a fear problem, not a glycemia problem. So the first thing we do is we determine a safe zone. So what blood sugar range do you feel comfortable with right now? If you're going to leave the house, what are you comfortable with? And that's the starting point. That's, in a way, the psychological safe zone. And then we don't make recommendations based on ideal. We don't recommend that you get your glucose levels, let's say between 7 and 9 right away. What if your safe zone is 12 to 15? What we do is we sort of start with that, and then we try to lower gradually the psychologically safe range till it becomes the medically safe range. So once you've got this on board, then there's this gradual strategy. It's important because it's a strategy that really engages you, so you're in charge It's not something that's done to you. And then you gradually are able to lower that psychologically safe range to the medically safe range. So I hope this has been useful to you. We've talked about diabetes distress. We've talked about fear of hypoglycemia. We've talked about psychological insulin resistance. And importantly, we've talked about positivism. Thank you.